All right, welcome everyone to the Adult Dialysis and Transplant Patients Current Trends and Opportunities session. Once we get started, please feel free to ask any questions you may have in the chat. We'll have some questions throughout the presentation and we will save some for our Q&A at the end. And don't worry, there'll be plenty of time for questions. It is my pleasure today to introduce Dr. Vimal Derebail, an adult nephrologist and an associate professor of medicine in Division of Nephrology and Hypertension at the University of North Carolina. His research interests include understanding the association and pathophysiology of thrombotic disorders in glomerular disease and end-stage renal disease. He is also involved in the management of end-stage kidney disease patients. Everybody, nice warm welcome for Dr. Derebail today. Appreciate your time.
Thank you for the nice introduction, Karen. Thank you to NephCure for inviting me today to speak a little bit. I will say I am a glomerular disease specialist and I do work in the dialysis clinics, and at one point was the director of our home therapies clinic here at UNC. So I've done a little bit in a lot of different spaces, and I'll hopefully be able to answer some questions and give you guys a little bit of insight onto things from our perspective of kidney disease and glomerular disease. So just to start with a few discussion points and an overview of what we'll talk about today, I'm going to go over a little bit about, just as a refresher of what the podocyte is and why that causes proteinuria and eventual kidney disease. We'll talk a little bit about the intersection of end-stage kidney disease and glomerulonephritis, and why this is a difficult space for us to study very well, just because it is a relatively rare disease. I'll discuss dialysis and transplant just at the basic level. And then we'll talk a little bit about disease recurrence after transplant in patients with glomerular disease, and go over some of the emerging research we're seeing in the setting of transplant, with particular emphasis on how that applies to patients with glomerular disease. This is a lot to cover in a pretty short period of time. So, I won't go into a deep dive in a lot of these things, but please feel free to stop and ask questions along the way, and I can answer them as we go through things, and we don't necessarily need to wait until the end if there's something particularly pertinent to talk about. So what is a podocyte? I'll start here because the focus of what NephCure has talked about today is largely in patients with proteinuric kidney disease, meaning lots of protein loss in the urine when we shouldn't be doing that. So within the kidney, we have these functional units called nephrons, and you have about 1 million of these in each kidney. And this is what makes up the filtration mechanism of the kidney. So blood enters into through what we call the afferent arteriole, which is a smaller blood vessel, into this little network called a glomerulus. So this is basically a ball of tiny little blood vessels that provide a large surface area relative to each little unit to allow blood to be filtered. And as blood filters through these little blood vessels, they're collected into this thing, this tubular system, which we call the convoluted tubules because they're all twisty and provide a large network. But eventually these will drain out of the kidney into the larger ureter. So these all eventually coalesce into these spaces that form urine. To focus on this glomerulus, because this is where all the filtration happens, this is where we see protein leak out of the blood and into the urinary space. So it's happening right at the start of where blood's coming through. And the glomerulus itself is, as I mentioned, this network of blood vessels, but over the top of these are these little octopus-looking cells called podocytes. And podo just means foot in Greek. So these are cells with little feet. And as you can see, there's these tiny little projections that come out of each of the cells, and they interdigitate or stick together and provide this barrier that prevents things from crossing out of the bloodstream into the urine, and allows the things that should be coming across to come across. If we look a little at a cross section of this, this is the blood space here. These are the blood vessel cells themselves, and there's a barrier called the glomerular basement membrane. That's why we get the term glomerular disease. And then we have the podocyte. So each of these little triangular shaped little blobs or pieces of a podocyte is sitting across the basement membrane, and you see they have these little slits between them that provide an area for elements from the blood to filter out into the urinary space. I really like this picture because it's I think it's just a pretty picture, but this is a scanning electron microscopy. So this is a very deep microscopic look at the outer surface of what these podocytes look like. And if the authors of this particular paper colorize these so that you can see that this is a network of 3 separate cells that are all kind of wound together to create this, filtration barrier all around those blood vessels that we talked about. And what we see happen in the setting of proteinuric kidney diseases, so diseases where you're losing protein in the urine, are these little feet are lost into something we call podocyte effacement. So instead of having this nice kind of lacy articulation between these cells, everything just is sort of lost and glommed together. And now all of a sudden things are wide open for protein to leak across. One of my pediatric colleagues, Keisha Gibson, who's our chief of pediatric nephrology, describes this as those feet suddenly stepped on hot coals and now they've just jumped back and there's nothing there to prevent protein from coming across. And I will say this isn't a feature unique to nephrotic syndrome per se, or FSGS, but this is something we see in any kidney disease that leads to lots of protein loss. So patients with really profound diabetic kidney disease who are losing a lot of protein will still have these same features. So what about dialysis and glomerulonephritis? So this is data from the US Renal Data System annual report. And so every year, the US takes data from all of the patients on dialysis and looks at different trends and outcomes and a variety of data, and that's published annually every year. And this is data from the 2020 report, but these are patients from 2018, so not too long ago. And this is looking at new patients who were starting dialysis in 2018. And in total, there are about 130 patients described here. And as you'll see, only about just under 10,000 of those 130,000 patients had glomerulonephritis. And this is a pretty big bucket. So this includes patients with FSGS, IgA nephropathy, lupus, vasculitis, the whole gamut of things that we see in that bucket of glomerulonephritis. And that only makes up about 7% of the entire end-stage kidney disease population. So you can imagine when we subdivide that down into even smaller groups, it becomes really hard to learn a lot of things specific to each of those populations because there aren't that many patients, which is a challenge with any rare disease. I did want to show this. This is taking that same graph, but looking at percentages. And I think one place that we're doing a little bit better with glomerulonephritis, because patients are often seen before they crash into dialysis and they're being followed by nephrologists, we see a higher uptake of peritoneal dialysis. So this is, as I'll talk about this is one of the other forms of dialysis, but a form of dialysis that can be done at home. And we also see more preemptive transplant, meaning that we do transplants before patients need dialysis. And you can see with diabetes and hypertension, those percentages are much smaller. So I feel like this is at least one place where we're doing well with GN patients who are entering end-stage kidney disease. So what do we talk about when we talk about kidney replacement therapy? So kidney replacement therapy is the big bucket of things that we talk about as ways to take over a set of kidneys that aren't working very well anymore. And this includes both dialysis and transplant. And generally speaking, we think about initiating kidney replacement therapy when someone's kidney function is less than 15 mils per minute, or roughly less than 15% of what normal would be, but mostly when patients become symptomatic. Years ago, the approach was if your GFR, glomerular filtration rate, was less than 15 and you were diabetic, that was a trigger to start dialysis. And if you were non-diabetic, if it were less than 10, that was the trigger to start dialysis. Over the last several years, we've learned that using that fixed number as a target to think about initiating dialysis based on that number, that has not led to a change in outcomes. So when we look at patients who start based on a fixed number versus patients who start when they become symptomatic or have a clear reason to need dialysis, the outcomes are about the same. So the thought process has been, why start dialysis for someone and put them through that big life change until we know it's going to be really helpful and make a difference? And practically, that has worked out to being when patients first start to demonstrate weight loss or malnutrition because of the buildup of the kidney toxins. And when other medical therapies have failed and have led to development of fluid overload or fluid retention, high potassium levels, high acid levels, and uremic syndrome. And uremic syndrome is a relatively broad group of symptoms, but those can include nausea, vomiting, persistent hiccups, loss of taste of foods or metallic taste in the mouth, bleeding because the platelet cells, the cells that make blood clots, are affected by those kidney toxins. They don't work as well. So there can be a whole host of things that fall in this bucket, but usually we don't see those until people are relatively advanced in their loss of kidney function. So as I mentioned,
we do have a question there.
Sure.
What can be done to increase preemptive transplants?
Yeah, so I think I'll get to that a little bit in the piece on transplant, but the biggest piece to that, I think, is educating patients and making sure they enter the process early enough to get worked up for a transplant. And largely, a part of the focus has been trying to broaden the group of people who could be kidney donors as deceased donors, and matching people to kidneys that would work best for them, but then also trying to expand our pool of living donors. So really educating people upon coming forward to donate kidneys if they're well enough to do so. And that's a big ask of people, but I think that's another place where we're really trying to push for that. I'm not sure that completely answers your question, but I'll go into a little bit more detail about some strategies that have been used to increase that process of transplant too. So as I mentioned, kidney replacement therapy includes dialysis, which has been the most common way to replace kidneys, replace the function of kidneys, I should say, versus transplantation. There are a variety of types of dialysis therapy. So there's hemodialysis and peritoneal dialysis. Peritoneal dialysis is generally done at home. Hemodialysis can be both done at home or more conventionally at a dialysis center. And there are forms of continuous dialysis. And this is usually reserved for patients who are critically ill in the hospital. So not something that we practically use outside of the hospital. At present, there are about 470,000 patients in the US who receive some form of outpatient dialysis therapy. As I mentioned, the most conventional has been in-center hemodialysis. And then home dialysis therapies make up less than 5 or 10% of that total. So this is really where we're lagging here in the US. In other countries, they're doing somewhat better depending on the country you look at, but this has really been the lesser well accepted form of dialysis therapy here in the US. So much like the native kidney, dialysis, the goal of dialysis is to try to improve the transport of solutes and water across the membrane. And what does that mean is that just as I described with that podocyte and the kidney's filter, we're trying to recapitulate that with dialysis modalities. Unlike the kidney, we don't have the way to synthesize the same hormones the kidney does, like vitamin D, erythropoietin, which is the hormone that tells your bone marrow to make blood. So there are deficiencies in what we can do with dialysis. And that's part of the reason there are still so many medicines we still have to use for patients who are on dialysis to make up for what we can't do with our technology so far. So dialytic therapies are really great for clearance of small solutes or chemicals that are not stuck to proteins or bound to proteins. It's good for maintaining acid-base balance, and it's good for removing fluid. Unfortunately, as I mentioned, it's not good at fixing issues with vitamin D, metabolizing certain toxins, or removing large solutes or large molecules that are stuck to other proteins as well. So there are some things that we just really don't remove very well with dialysis. Just as a quick overview of what dialysis looks like. So this is a typical hemodialysis treatment. So we have our patient, we have blood coming out of the patient to the dialysis machine through the kidney filter. The filtered blood is returned to the machine. On the other side of this filter, so there's blood crossing through these tiny little hollow fibers in the dialyzer filter. On the outside of those fibers, we have fluid, and that's what we call our dialysate. And that's made as a combination of water, a dialysate concentrate, and then a mix of bicarbonate. So that's all mixed together to come up really with what we'd expect blood fluid to look like, or provide a way for us to move those toxins in the blood out into that fluid. We can make some additional adjustments to the dialysis treatment, including adjustments of dialysis temperature. And that's done sometimes when patients have very low blood pressures. We will sometimes drop the temperature at dialysis to try to help keep their blood vessels constricted so their blood pressure doesn't fall during the dialysis treatment. So not only do we air condition the heck out of every dialysis unit, there are some times where we purposely make patients a little bit colder. So that's an unfortunate, but sometimes effective way to help prevent that problem of low blood pressure in dialysis. In order to do dialysis, we have to plan for vascular access. And so we have 3 ways of getting blood out of the patient into the dialysis machine and back to the patient. One is something called an arteriovenous fistula. This has been the preferred approach for the majority of patients because it has the lowest infection rates. We're able to run blood through the machine faster so we can get more efficient cleaning. And these are likely to last the longest. One of the downsides here, and I apologize for the typo, but these take about 8 to 12 weeks to mature. And that's assuming that nothing goes wrong. So as we're planning for patients, if we don't think we can get them transplanted preemptively and we're having to plan for dialysis, we really try to start those conversations about 6 to 8 months before we think we need to start dialysis. And that's a little bit of a ballpark guess for a lot of patients because we don't have a great way to plan that trajectory for everyone. But ideally, we start thinking about getting a fistula into a patient who's chosen hemodialysis as their modality about 6 months before they're going to need to start dialysis, because that would allow us to let the fistula mature and heal. And if there's any issues with the surgery that the surgeon will need to go back in to repair the fistula or do any other interventions, we have time to do that before a need for dialysis becomes emergent. The second best access, if you will, is something called an arteriovenous graft. So this is very similar in concept. Here we're connecting an artery and a vein together, and we're doing the same thing here, but to connect that artery and a vein, there's actually a piece of graft material. So this is a piece of Gore-Tex usually that connects the artery to the vein, and we actually stick the graft, this material, in order to get blood out. It does have a higher infection rate than arteriovenous fistula, but it's all still enclosed, so it's not as high as anything that's hanging out of the body. It doesn't last as long because you can imagine if you're sticking 2 needles into this plastic piece over and over 3 times a week, you're going to end up tearing that up after a while. So it doesn't last as long as a fistula. We do have some patients who are able to maintain these grafts for years, but generally speaking, it's not going to last as long as the fistula. One upside to these is that they can be ready to use fairly quickly. Over the last few years, we've seen the appearance of what they've described now as quick stick grafts. So those are grafts that can be placed and used the same day for surgery, after surgery. Generally speaking, though, it's about a 2-week time to heal. So much faster than a fistula, but comes with those downsides I described earlier. Our least preferred way of doing this is with a central venous catheter. So this is what you may have seen a lot of patients who come out of the hospital have. This is a catheter that goes into the jugular vein, and then it's tunneled under the skin and has a little cuff that allows the little catheter to hang out and allows blood to be taken out from one side and put back in through the other. These can be used right away. So in patients who have not been following the nephrologist or we've lost a follow-up and show back up in the hospital really, really sick and needing dialysis emergently or urgently, we can place a catheter like this and start dialysis right away. And then once these go in, we usually try to get either a graft or fistula into the patient if they're going to stay with hemodialysis later on and get these out as quickly as we can. As I mentioned, these are less preferred because they have the highest infection rate because you have something out of the body that's entering the bloodstream. It can cause injury to these central veins. So sometimes we'll see these veins get strictures or tightened down, which can cause other problems. But as I mentioned, they can be used right away. So peritoneal dialysis, this is conceptually very different than hemodialysis, but kind of the same idea in the bigger picture. So we have a membrane and fluid around the membrane. And the membrane here is your natural lining around the inside of the belly, something we call the peritoneal membrane. And it's hard to conceptualize this, but I tell people if they've ever stuffed a turkey, if you look in the inside of the turkey as you're stuffing it, there's that shiny lining on the inside of it. And that's effectively the same idea. That's a membrane. So your body has a variety of these kind of tissue coverings around certain spaces. And here around the belly, there's the peritoneal membrane. And that has a lot of tiny little blood vessels going through it. So it can almost recapitulate what we do with dialysis because we have a membrane, blood on one side, and then we can place fluid on the other. And that's done through a peritoneal dialysis catheter. So this is a small catheter that's placed in the belly. And I'll show you a picture of what that looks like outside of this if you're not familiar with it. And we're able to introduce fluid into that space. The toxins and water are absorbed into the fluid through the peritoneal membrane. And then we can drain out that dirty fluid, as we call it, and replace it with clean fluid again to continue through the process as well. This can be done in two different ways. So there's something called continuous ambulatory peritoneal dialysis. And you can see that this is relatively simple to do, if you will. It doesn't require a lot of technology. We're able to do this in very rural parts of the world where there isn't necessarily electricity. As long as you have a bag of dialysate and sterile tubing and a place to hang that bag, you can drain fluid in and drain fluid out. The alternative to this is something called continuous cycling peritoneal dialysis, or CCPD. And with this form of dialysis, we do multiple exchanges, usually overnight when a patient's asleep. The machine gets set up, and I say when the patient's asleep, but let's be fair, if you're hooked up to a machine, then you may not sleep all that well, but most patients are able to do fairly well with it. But the machine will instill fluid in, allow fluid to drain out, and then reinstill fresh fluid, allow it to drain out. And then the advantage with this is that because the machine's doing this overnight, we can do multiple exchanges up to 8 or 10 a night for a patient. So it's a little more efficient than ambulatory peritoneal dialysis, where everything is dependent upon gravity and can take a little bit longer and is relatively time consuming. But either of these can be, great modalities. Some advantages to these and disadvantages, if you will, is that these are done usually on a daily basis. So it's a little more gentle than hemodialysis. So conventional hemodialysis at the dialysis centers 3 days a week. This is done 7 days a week. And it's a little more gentle. We don't remove as much fluid in a single session as we do with those 3 days a week hemodialysis sessions. So patients tend to tolerate that fluid removal a little bit better. And generally speaking, they don't feel as washed out usually after peritoneal dialysis treatment. And of course, this is what I'm told by patients, not what I necessarily know, but we generally think of this as a more gentle way of doing treatments. So what are the goals of dialysis? And this is a quote from one of our patients here at our center: is it allows you to do what you want to do with the rest of your life. But that's a relatively loaded statement and means a lot of different things to different people. But the bottom line is that it allows you to stay well enough to keep going. And whether that well enough to keep going is because you're older and you want to stay alive, and you may otherwise not have the ability to get a transplant. But if you are eligible to get a transplant and well enough to tolerate that procedure, dialysis is a bridge to get you there. And that's a big emphasis for us for a lot of patients, especially patients who are relatively young and look at dialysis as this endpoint. For us, it's not the endpoint. We don't want it to be the endpoint for the patients. We want that to be the way we keep them well so that they can get a transplant down the road. So coming down to transplant, I just wanted to show this one picture. This is again from one of the national data registries, the SRTR. And here, if we look at transplants, what I will point out is over the last 5 or 6 years, the number of transplants we're doing has started to pick up. So when you talk about trying to do preemptive transplants, we're doing more preemptive transplants and doing more transplants for patients who are on dialysis. So we've been able to slightly push that a little bit more than we were in the past. How does the kidney transplant surgery work? So if we look at your native kidneys are here, the transplanted kidney is actually placed down here in the pelvis, and it's sewn into your blood vessels. So these are the blood vessels that would eventually come down to your leg, what we call as the iliac artery and iliac vein. I show you this largely to point out the importance of having healthy blood vessels. So if you have someone who's older, in their 70s or 80s, has had bad diabetes, bad blood vessel disease, if these blood vessels aren't very healthy, the surgeons can't actually sew into the vessel. And they describe it as trying to sew into a piece of porcelain. So there are some of our patients who've had bad blood vessel calcification, meaning the vessels have gotten really hard, and they're deemed not candidates for transplant because of that. This is pretty uncommon to see in young patients, but it's usually our older population where that becomes an issue. So is transplant better than dialysis? I think most of us here would probably say the answer is usually yes. And then there are multiple studies of this that have been done over the last several years. And I bring up this one because it's kind of the most classic, and it was published, I think in 1999 in the New England Journal. And this was looking at all patients on dialysis comparative to patients who received deceased donor transplants. And if you look at the rate of death over a 100 patient year period, so if you took 100 patients who lived a year, 16 of those patients would die if they were on dialysis versus 3.8 if they'd received a transplant. Now, a lot of people have said this is an unfair comparison because patients who are able to get transplants as a whole are probably healthier than dialysis patients as a whole. So the comparison that people have really tried to do over the last several years is compare patients who are still on the wait list waiting for a kidney to those patients who actually got a kidney already. And if you look at the rate of death, it's still there. That's about half of what it is if you were to not get a kidney, but be well enough to be eligible to get a kidney. And when we break down this across age groups, it still maintains that difference all the way down, even among patients with diabetes. So no matter how we really split this up, generally speaking, the transplant is going to be better for dialysis in terms of length of life. And when we compare this to dialysis, if we look at a native kidney and how often it's cleaning the blood or how much blood it's able to clean over a week, this is what we're able to do with hemodialysis and peritoneal dialysis. And this is what a healthy native kidney can do. And so obviously what we're doing with hemodialysis and peritoneal dialysis doesn't compare anywhere to a completely healthy kidney. And again, once we have a healthy kidney back into a patient, we see improvement in their anemia, we see improvement in bone disease, we see improvement in blood pressure. So all of these things that aren't necessarily just about moving stuff in and out of the blood, we're also able to pick up that hormone replacement that a healthy kidney can do now. So how are kidneys matched to patients who need them? And this goes back to your question earlier about how do we increase the rates of preemptive transplant? And this has been one way to do this. And so probably 5 years ago now, I think this program entered into the way we've allocated kidneys to patients when they come from deceased donors. And so every deceased donor kidney is given this kidney donor profile index, or a KDPI. And it's an estimate of how long a kidney is likely to function. And so if you get a KDPI score of 20, then it's going to last longer than about 80% of other available kidneys. So that's a pretty good KDPI score. And there are a variety of things that go into determining that KDPI, including age of the donor, their height, their weight, their ethnicity, how they died, whether they had a stroke, whether they had high blood pressure, whether they had diabetes, whether they had exposure to hepatitis C, and what their kidney function was at the time of death. That's matched to something called an estimated post-transplant survival score. And so this is an estimate as a guess to say how long would someone need a kidney. So if you're in your 70s, you may not need a kidney that lasts 30 years. But if you're 20 or 15, you'd need a kidney that would last as long as you possibly could. So the idea here was that rather than just taking every deceased donor kidney that came up and saying, this is the next deceased donor kidney, they're a pretty good match for this patient, let's call this patient first. The idea is that now we can take kidneys and match them better to patients who need them. So there are kidneys that were probably less well off, if you will, that were being discarded in the past, but now those patients are being offered to patients who are in their 60s, 70s, 80s that still want to get a transplant. The estimated post-transplant survival score is determined by their age, how long a patient may have been on dialysis, whether they've had a previous transplant of any organ, and whether they have diabetes. Those all go into their estimated post-transplant survival score. This past, I guess it's been 2 years now, there's been this executive order called the Advancing American Kidney Health Act. And this has also been something that's both tried to improve what we do with dialysis care, but also increase the number of kidneys available for transplant. So the goal with this was, one, to reduce the number of people reaching end-stage kidney disease by 25% by 2030. I'm just going to read these top ones because these are the most relevant pieces. To try to get 80% of new patients either on home dialysis or transplanted. And this is a little bit of a lofty goal, I think, but I think this is a great target to shoot for. I will say the one thing that we probably don't communicate as well to patients is that home dialysis, while I think almost every nephrologist would say this would be the modality most likely to help you maintain your lifestyle, is that it is a lot of burden on the patient. It is well supported by every single dialysis unit, but it is a lot of work for people. So there are times when people would get burned out after a while, and we have to figure out how to support them through that period. Which can be sometimes going back to regular conventional dialysis for a short period in the dialysis center, just to give them a break and then let them come back when they kind of feel like they can do it again. But I think this is a fantastic target to have. And the other part of this is doubling the number of kidneys available for transplant by 2030. So one goal is to try to increase the utilization of available organs from deceased donors and reducing what we call the organ discard rate, and increasing the number of living donors by removing disincentives to donation and providing financial support. And this is a big one in what I talked about earlier, because for a lot of patients who have donors that want to donate a kidney, the recovery time after donating a kidney can be relatively long for some patients. We see the occasional donor who bounces right back, and a week later they're perfectly, nearly back to normal. But for most people, it can take several weeks to get over this. And so that's time out of work that may or not be covered by their work. And so there are now legislation to try to look at how to help donors who want to give a kidney be able to maintain their employment and cover their own finances if they have to be out of work for a long period of time, or if they need support at home to take care of their kids or whatever other things might be, a big problem if you were knocked out for 6 weeks. So what about recurrence after transplant? So again, a lot of these studies have looked at glomerular disease as a whole. So with bits and pieces looking at FSGS or membranous or the other proteinuric kidney diseases. But if we look at recurrence of disease after a transplant, the highest rates of recurrence occur in patients who have MPGN or IgA nephropathy. If you have a recurrence of MPGN in your transplant, the likelihood of losing that transplant is very high. For FSGS patients, it's about a third of patients who'll have a recurrence. And it's more common in patients who are a younger age at the time of transplant, and less common if patients are on prednisone as part of their transplant therapy. And that's been demonstrated particularly for IgA patients. A lot of transplant centers prefer to use steroid-sparing regimen for their anti-transplant or anti-rejection medication. So most patients out of a transplant nowadays will be on a medicine called tacrolimus or Prograf, MMF or Cellcept or Myfortic, and then plus or minus prednisone, depending on the preference of the center. And again, there does seem to be, especially for IgA patients, some benefit if they stay on prednisone. I think there's one question here in the chat. Should I go ahead and grab that one? You think you're?
Yep, I have it here. So it is, with regard to IgA, would you recommend a familial donation as an assister, or would it be better to look for a non-family living donor?
That's a great question. There are some familial forms of IgA nephropathy. If that potential donor doesn't have evidence of blood or protein in the urine, and they're presumptively mid-adult, that's probably okay. And if there's not a long family history of IgA nephropathy. I actually just saw a patient of mine who moved here from France and has a wide family history of end-stage kidney disease. And it sounds like one of his family members actually was told he had IgA nephropathy, but it took probably 3 weeks for us to figure that out until he just brought up the name randomly. I'm like, why didn't you say that the first time we met? But yeah, so in those situations, I'd be a little less comfortable saying that a living family member should be a donor there. But if that potential donor doesn't have blood or protein in the urine, it's probably safe. Donors go through an enormous workup, and sometimes to a frustrating amount to both them and their potential donee or recipient. And I think the process of screening donors is so stringent that it's really unlikely that that patient's going to make it through, or that donor is going to make it through if there's any concerns seen at all. And I think one of the common things we teach people is that when you compare our donor population, so patients who've given a kidney, to the general population as a whole, they actually live longer. And that's because we've selected out this really healthy group of patients. Not that giving up a kidney makes you live longer, but when we take patients who've given up that kidney, have been healthy enough to donate, they're so healthy they live longer than the general population, even after having that donated kidney taken out. I think there's one other question here. I should go ahead and grab that one, or maybe.
Yep, so it is it less likely to qualify for a second transplant if you had FSGS with recurrence after a first transplant, and remission was obtained with plasmapheresis and rituximab?
Just to clarify, was that remission in the first transplant that was achieved, or pre-transplant remission was achieved with plasmapheresis and rituximab? So I'll give you a minute to answer that. Okay. Yeah. So, if they're in remission and their kidney function's okay, and they were able to achieve remission, but for whatever reason that graft is lost over time, that wouldn't disqualify them from getting a kidney. I think it's usually done with the caveat that there is again a higher chance of recurrence if you've had recurrence in your first transplant. And I think I'll get to that here actually. So previous graft failure from recurrence is, one of the identified risk factors for recurrent FSGS in a transplant. But, I think we usually will give, if it's something where we've seen this they've had early recurrence of FSGS that we couldn't get under control after a transplant, and we try a second transplant and the same thing happens again, that usually will be, at most centers, enough of a concern that they would say this is probably not a good idea. And usually in that setting, they would recommend a deceased donor for that second transplant, so that, I guess there's less concern about taking a kidney that you may not, you may lose from someone who's living, than there is taking a deceased donor kidney that may come along. So it's not a hard stop necessarily, but I think in the context of what happens, most transplant centers will look at that and recommend, what the risk of that would be. So this is data just on patients who have FSGS and whether they have recurrence after transplant. So the risk of recurrence is about 20 to 50%, as I mentioned, to about a third of patients in general. There is something in a secondary FSGS. So if you have FSGS, but you have some other underlying disease process that's caused the FSGS, the one I think of often is either obesity-related FSGS or sickle cell disease. And so that depends on the underlying disorder, whether we see a recurrence afterwards. Recurrence in primary FSGS can be very early in onset and sometimes within hours. And so within a day of the patient getting transplanted, we'll sometimes see the development of this protein spilling the next day. And usually it does occur within the first year. And if it occurs that really early, it's thought to be related to what we've called the circulating permeability factor. So some molecule in the blood that allows that filtration barrier to come apart and let protein leak through. That sounds really nebulous, I think, but it's because we've never really been able to identify exactly what that molecule is. But that's why patients who have this develop early on are recommended for plasmapheresis, with the idea that we can try to remove that with pheresis. Risk factors for recurrence in primary FSGS include patients who got transplanted and developed end-stage kidney disease at a younger age, if they had a very aggressive course in native kidneys, if they're non-African American race. And I did want to mention APOL1 risk variants. So Josh Tarnoff mentioned this earlier this morning, and these APOL1 risk variants have been identified in patients of African descent as to be a risk factor for end-stage kidney disease. And to be very clear about that, it doesn't mean that if you have these risk variants, and it usually means having 2 risk variants, so one on each chromosome, it doesn't mean that you're going to get kidney disease or end-stage kidney disease, but it just increases the risk. So if you look at patients who have those risk variants compared to those who don't, your chances of getting kidney disease are much higher, but it's not 100% guarantee. So it's not like some of these other mutations we know that directly lead to nephrotic syndrome. What's interesting about APOL risk variants is that the recurrence of FSGS in that kidney is actually linked to whether the donor has 2 risk variants and not the recipient. So recipients who have 2 risk variants and get a kidney without APOL risk variants, they do just as fine as anyone else would. If they get a kidney from someone who's had 2 risk variants, then they are likely to have recurrence of FSGS. Again, this isn't a hard stop, and there is potentially the risk of kidney disease in the donors who have 2 risk variants, but that's something that's kind of discussed both with patient and donor at the time, and you really only screened at the time of living donation. And again, as we talked earlier about previous graft recurrent failure being another risk factor recurrence. I did want to mention these. So these are some of the mutations we know that lead to primary FSGS. So one is called an NPHS1 mutation or nephrin mutation. So this is one of the proteins that helps make up that filtration barrier between the podocytes that we talked about earlier. About 25% of patients who have this mutation will develop a recurrence, and it's because they don't have this protein. And so when a new kidney comes along, they've received someone who has an intact protein, their body recognizes that as foreign. So they develop antibodies to that protein. And so It's actually a different process of getting nephrotic syndrome, but related to that mutation. If you have something called an NPHS2 mutation or a mutation in something called podocyte, the rates of recurrence are really low.
There is a
There's one question.
question there. Okay. Yep. I was diagnosed with bronchiectasis, and my nephrologist stated my infection would have been better under control before my transplant status can be reactivated. What are transplant teams looking for in terms of infection being under better control?
Yeah, this is a tough question, and I think with bronchiectasis, it's particularly difficult because that can be a recurrent infection. But usually, if someone gets a bad infection while they're on the list for a transplant, they'll be temporarily deactivated. They're not taken off the list, so they're still earning time during that period. But just if a transplant were to come along that would be a match for them, they wouldn't be offered it at that time, because if you have an active infection and we give you a bunch of immunosuppression, that infection is going to get worse and you could die from that. So that's paused for a little bit. The earning time still happens, so you're not disqualified from a transplant, but you're just on pause, if you will. For bronchiectasis, I imagine it would be, if you've completed antibiotic therapy and you're not having as much of a cough, you're not producing a whole bunch of other stuff, your x-rays or CAT scans look better. That's usually what they're looking for to decide if it's cleared. And ultimately, whoever's treating your bronchiectasis would probably have to weigh in to say whether they think this is a safe time to go back active on the transplant list. And if you were to get another infection, they might pause you again until you get over that infection, just so that if that happens, you're not shocked by that. So I don't know if you have a lung doctor that's helping with managing your bronchiectasis, but that would be kind of the person to talk about and see when they thought it would be safe. And ultimately, it falls into the lap of the surgeons to say whether they think it's safe too. But I think getting input from whoever's treating you for the infection is hugely important. So this is also data on recurrence of FSGS, and this is from a recent registry that was established a few years ago called TANGO, and I'll talk a little bit more about this later. But this is a registry specifically to look at recurrent disease in patients who had some form of glomerulonephritis prior to their transplant. And this is recruited patients from 2005 to 2015. It's still ongoing now, so they're still looking for patients. This abstract's a little bit misleading because they talk about 11,000 patients with glomerulonephritis that were part of TANGO, and that is the number of patients in the registry. But within this one study, there's only 176 patients who had FSGS pre-transplant. And you can see that as patients got older, their risk of recurrence went up. If they were non-African American race or white race again, if they were heavier, their risk was actually a little bit lower. And if they had the native kidney removed, and I'm not sure why they thought this was the case, but it turns out that was also a risk factor for recurrence. Again, about a third of patients had a recurrence. And of that third, nearly 40% lost their kidney over a time of about 5 years. They looked at treatments, and this is not a clinical trial. This was just seeing what people did to treat the recurrent FSGS. And about 81% of patients who got plasmapheresis and or rituximab to treat the recurrence. And with that, about half of patients had some remission. So complete remission we usually talk about as being complete resolution of that protein spilling with preserved kidney function. Partial remission is usually about a 50% reduction with preserved kidney function, as long as that protein spilling is below some threshold after that. But you can see the complete remission rates are not terribly high. It's only about a fifth of patients will get there for that. So we still haven't figured out exactly how to treat this well, I would say. What are the therapies for recurrent FSGS after transplant? I mentioned plasmapheresis because we think we might be removing the circulating factor. If there's a lot of scarring on the biopsy, this is likely to be not helpful. It can take many months to have its effect. So even if we do several sessions of plasma exchange and we don't see a response, sometimes continuing that out longer can be helpful. There is some data to suggest that it can be helpful with prophylaxis. So if you had recurrence of FSGS, as I think it was Lisa that mentioned earlier, in that first transplant, if the person is going to need a second transplant, doing plasmapheresis before that transplant might be helpful and may reduce the risk of that recurrence in the second transplanted kidney. So some centers will do that before they plan that second transplant. Obviously, that's really only practical when you have another living donor, because you can't plan for it around a deceased donor kidney. Rituximab has been used, and I would say that's often a standard thrown at patients. And we do it with some caution because it does increase the infection risk, because this is adding more immunosuppression on top of what we've already given for the transplant. There seems to be more likelihood of benefit if the protein level in the blood is still normal and if the patients are younger. A couple studies have looked at this as prophylactic therapy before that second transplant after someone's had a recurrence. And that data is kind of a wash. So some studies have shown a little bit of a benefit and others have shown no benefit. So that isn't necessarily employed at every center. There is a medicine called ACTH gel, or Acthar is the brand name. So this is a synthetic version of a hormone your body already makes that mimics steroids. And it has some other non-steroid effects as well. And it's been studied in patients with nephrotic syndrome or protein spilling for years, and has this grandfathered FDA approval from the 50s for it. But this is a case series of 20 patients who had FSGS, who had either a recurrence or a new diagnosis. So meaning they either had FSGS before their transplant and when the end-stage kidney disease got a transplant, or they didn't have FSGS pre-transplant but had some other form of kidney disease and then developed FSGS in the transplant. So it is a mix of patients. Most of these patients have already failed other standard therapies, including rituximab or plasmapheresis. And with treatment with ACTH gel, they did see an improvement in protein spilling for a large majority of the patients that were reported here. But the kidney function itself didn't necessarily improve in a lot of patients. So these kidney creatinine values before Acthar versus after didn't really change very much, except for I think this one patient had pretty profound kidney function loss at the start. So there may be some potential benefit here, but it's still relatively unclear. LDL apheresis is something else that's also being studied both in FSGS pre-transplant and post-transplant. Largely these data are from case reports or case series. And the way this works is not totally dissimilar than from dialysis or plasmapheresis. But with this, blood is removed from the patient and it goes through something called plasma separator to pull out the plasma from the blood. So this is the part of the blood that doesn't include white blood cells or red blood cells. And then it's gone through this LDL column. So it pulls out all the lipids. And then that plasma is returned back into the blood and back to the patient. This is interestingly approved for FSGS post-transplant already on the basis of these few case series that have been published, but also because this is such a hard disease to treat. It's also approved for patients who have very, very high cholesterol levels, usually related to a familial disease, so a hereditary form of high hyperlipidemia or high cholesterol. So that's the other place where it's usually employed. There are a few reports in adult patients. There's a single case series of 7 treated pediatric patients where 6 of 7 patients had stable to improve GFR, protein improvement in all of the patients, and albumin in the blood that improved in all of the patients. So there is some potential signal here that this can be helpful. And again, as I mentioned, it is FDA approved. There is an ongoing study now to get additional information on this, and this is mentioned in the Kidney Health Gateway study, Kidney Health Gateway website. And the study is called the Liposorber trial for adults with FSGS. Liposorber is the name of the column that's used in that treatment. I actually stole this from NephCure, but this was a handout that was coming out of patients. So I thought it was worth discussing some of these really quickly and just describing the current trials going on for patients who've had a transplant. One is starting up in Spain. It's using a technology called photopheresis, which is kind of interesting. And so this is the same idea. We're moving blood out of the body and back to the patient, but as that blood moves out, it's exposed to ultraviolet light that seems to settle down the immune cells so that they don't necessarily recognize the transplant as being foreign. So that's one approach that's being tried. This is not a new technology necessarily. It's been used for several types of autoimmune disease and certain types of skin cancers as well. But I think this is a relatively novel in its employment here for transplant. I mentioned just a little bit ago the Liposorber study. Again, this includes patients specifically with FSGS post-transplant, but also FSGS patients pre-transplant, and using that Liposorber system. There's a study from Bristol Myers Squibb looking at modulating T regulatory cells. So T cells are part of your white blood cell arm, and they're responsible for helping fight infections and also involved in recognizing the transplant as a foreign organ. And the T regulatory cells are a subset of those overall T cells that have kind of this policing function, and they usually tell the overactive T cells to settle down and not be as active. So the idea here is that you can upregulate those T regulatory cells and make them more active to tell the rest of the immune system to not be so jumpy when they see a new transplant, if you will. And this is using 2 separate drugs for this. Freedom study, this is an interesting study. So this is actually looking at stem cells from a donor. So at the same time that a kidney is given to a patient, the same donor would give stem cells, and those are given to the patient at the same time. And it seems to lead to this understanding of the donor kidney not being foreign and being recognized as self. And the goal with this therapy is actually to try to do this and then not have to keep patients on anti-rejection therapy long-term, hence the name Freedom. So this is, I think, a really exciting potential opportunity if you have living donors. I mentioned to you these T regulatory cells earlier. This is a study by Novartis. And what they're doing here is they're actually taking a patient's T regulatory cells from a blood sample that they give through cell apheresis. So again, moving blood through a machine again and pulling out those T cells. And then they take those T cells to the lab and they let them grow out. So they expand them and let you develop a larger volume of those cells. And then those cells are given back to you. Sounds very sci-fi, but it's your own white blood cells. So the risk of reactions to that are really low and the side effects of that are relatively low. But again, you increase the numbers of those regulatory T cells to tell the rest of the immune system to calm down. Again, this is being used in patients with new transplant. The SIRA study is another study of drugs using, it's a novel drug agent that's supposed to try to replace tacrolimus or cyclosporin in the arm of kidney transplant medicines. Those medicines work great. Unfortunately, long-term, they can themselves cause some injury to the kidney or toxicity. So the hope is that this new drug might be able to supplant those and not have as much damage to the kidney long-term related to the drug itself. And then finally, there is another study called Empathy. So this is looking at a drug called empagliflozin. So this is a drug that's actually used to treat diabetes, but this class of drugs, what are known as SGLT2 inhibitors. Over the last couple of years, there have been several studies that have demonstrated that these agents can help reduce kidney function loss, regardless of the cause of kidney disease. And in particular, in some patients with glomerular disease, specifically IgA, it might be a particular benefit. One of the cousin drugs, known as dapagliflozin, was just approved by the FDA for this indication for chronic kidney disease. This is kind of a big deal because this is not just patients with glomerular disease, it's kind of anyone with reduced kidney function at all seems to probably benefit from this, with some side effects, but relatively tolerable. There are a couple other studies. One is a drug called pegcetacoplan that's being looked at for transplant recurrence in patients with C3GN or MPGN. I mentioned to you the TANGO study. I think this is going to be really informative for us understanding how patients with glomerular disease do post-transplant. So if this happens to be you, I would highly encourage you to look at trying to enroll in this. This is not a drug study. They're just asking for blood sample to try to understand what things are noticeable in the blood before people develop a recurrence or after they develop a recurrence. And if you remember when I showed you that big chart of patients with end-stage kidney disease, we're talking about less than 10% of our population on dialysis has a glomerular disease. So trying to understand what that population does in transplant is hugely important because we don't have numbers. So anyone who can contribute to this is hugely important. And then finally, there's something called the genetic study for kidney disease that's being run out of Martin Pollock's lab up in Boston at Harvard. And they're looking for patients with primary FSGS nephrotic syndrome, unexplained protein in the urine, and or unexplained kidney failure. And again, asking simply for a blood sample to look at genetics that might contribute to kidney disease. I have a couple of quick acknowledgements. One, again, I'd like to thank NephCure and Kira and Kelly Helm both for being patient with me this week on getting some slides to look at. And my colleagues at UNC, Abhi Shirsagar, who's our overall director of dialysis, Karen True and Pankaj Jawa, who all helped me. The latter two are two of our transplant docs who helped me put some of this presentation together this past week. And I'll stop there.